students, this is your Dr. Prats and welcome to my masterclass. This is the third series under Odontogenic cysts, and today we are going to talk about OKC or Odontogenic keratocyst, which in fact is considered as an aggressive tumor. Let's roll. Again, we are going to follow the same questioning format. What is the pathology? Why do we need to understand the pathology? How did it occur? That is the etiopathogenesis. How to diagnose by using investigating tools like radiography, histopathology, and other histotechniques, and how to treat, which is the most important aspect as a practitioner. Followed by a summary of whatever we discussed today and tips and tricks to answer multiple choice questions. Every lesson must have an objective, and at the conclusion of this presentation, you will be able to describe the etiopathogenesis, clinical features, types, radiographic features, histopathological features, and differential diagnosis and treatment of odontogenic keratocyst. Aspiration is one of diagnostic tools, especially when it's a cystic lesion, and we'll see how that helps in case of odontogenic keratocyst. Causes of recurrence of parakeratinized odontogenic keratocyst, potential complications of the same, followed by a brief discussion on ortho-keratinized odontogenic keratocyst. It was Philipsen in 1956 who coined the term keratocyst, and it is used to designate a very specific entity within itself which has characteristic histological appearance and a very specific clinical behavior, which basically indicates an aggressive growth potential and a tendency to recur after surgical removal. But this definition is now applied only to a specific type of odontogenic keratocyst, that is parakeratinized type. We will discuss the types as we continue. Even WHO came up with a definition which we are going to discuss now, and according to WHO, they actually consider the parakeratinized odontogenic keratocyst as a keratocystic odontogenic tumor. It is not considered as a cyst, but because of its very aggressive nature, it is more considered as a tumor. And the definition given by the World Health Organization is that it is a benign. It is still a benign tumor, just very aggressive. It's not malignant. Do not get confused. It is a benign, unicystic or multicystic intraosseous tumor. This is very important. The tumor begins within the bone. It is of odontogenic origin, and it has a characteristic lining, that is parakeratinized stratified squamous epithelium, and a potentially aggressive infiltrative behavior. So because of this aggressive infiltrative behavior, it is termed as a tumor. It can be either solitary or multiple, and the multiple OKCs are characteristic of nevoid basal cell carcinoma syndrome. So this is the definition. The definition itself indicates what's the nature of the tumor, that it is intraosseous and that it is unicystic or multicystic in appearance, which will be a similar appearance in radiograph as well. And the lining, they have already described that it is parakeratinized stratified squamous epithelium, and it has a potentially aggressive infiltrative behavior. And in case they present multiple in number, it is associated with a syndrome. Let's move on to the types. I've going on telling you that it is parakeratinized type, which is aggressive. So let's see which is the other type. So the main type is central type and peripheral type. Central is nothing but intraosseous, and peripheral is something which arises in the soft tissue. Okay? And under central, there is parakeratinized type, ortho-keratinized type, and there is a combined type which has both parakeratin and ortho-keratin type. So parakeratotic OKC is the aggressive one, whereas the ortho-keratinized OKCs are regular in behavior. It behaves as a simple cyst. We will see how they both behave and how they can be diagnosed and treated. Let's move on to how it is formed, or the pathogenesis. Please go back to the first lecture on the cysts of oral cavity, where I have discussed the pathogenesis of all cysts. How it is initiated is where you will find all the sources of its origin or initiation. Dental lamina or its remnants, that is cell rest of serae, are involved in the pathogenesis of this cyst as well, along with the basal cells from the overlying oral epithelium. Both these were discussed in the first lecture, so please go back and look if you have any confusion in understanding this part. There was a contradiction to believe that dental lamina is a source for the pathogenesis of OKC, because more than half of the OKC arise in the ascending ramus of mandible, where no dental lamina is found. There is an absence of dental lamina in this region. Hence, there is a question as to, is it the dental lamina and its remnants which is responsible for the origin of OKC? So, recent concept is that PTCH gene is what is responsible for the pathogenesis, especially for the parakeratinized type of OKC, because this is involved in proliferation and tumorigenesis. The rate of growth of OKC is 2 to 14 millimeter a year, which is pretty big. As you can imagine, 14 millimeter is quite huge in size. And the reasons or the causes of enlargement, number one is osmolality. Again, I have discussed enlargement of a cyst and the factors associated with it in the first series of the cysts. Please go back and look at it again for detailed explanation. Here I'm just going to name them. Osmolality is dependent upon the protein content, and as you know, keratocyst comes from the word keratin, because the cyst is filled with keratin, which is a protein, because the protein content is high. Okay, so osmolality is playing a role here in the enlargement of the cyst, followed by inflammatory exudate, bone resorption factors, collagenolytic activity, interleukins, tumor necrosis factor, matrix metalloproteinase, myofibroblasts, and of course the PTH related proteins. Coming to the clinical features, it shows a bimodal occurrence, and the peak frequency is seen both in second and third decade of life. Women are most commonly affected, and whites are most commonly affected. Mandible is more commonly affected than the maxilla, and angle of the mandible and ascending ramus are what are commonly affected. Even in this image, you can see that it is situated in the posterior mandible. It is usually asymptomatic, sometimes can be associated with pain and swelling, and even a discharge at times. Paresthesia of lower lip, that is partial paralysis of the lower lip, can sometimes be associated, especially when the lesion is really large and is very close to the nerve and is applying pressure. Pathologic fractures are common because of the enlargement of the cyst, and expansion of the bone occurs in later stages. Displacement of adjacent teeth is another common feature of this cyst because of the pressure applied by the enlarging cyst. Involvement of the maxillary sinus could lead to destruction of the floor of the orbit, resulting in proptosis, as you can see in this image. That is another very important clinical feature. Radiography as investigation shows either unilocular or multilocular appearance. So you can see here that this is a multilocular or soap bubble or honeycomb. There are several names which are given to this. So when you make a soap bubble, soap water bubble, this is how it looks, isn't it? There are a lot of bubbles which are joined together. And honeycomb, if you've seen a honeycomb, it also resembles pretty much the same picture. That is why a multilocular radiolucency is termed as honeycomb appearance or soap bubble appearance. And as you can see here, the angle, a little bit of ramus, and the body of the mandible is affected. Whereas here you can see that it is the body, the angle, the ramus, and it is extending almost up to the processes. The cortex appears scalloped and the borders are sclerotic. As you can see here, the borders are showing sclerosis. And if there is any perforation of bone or pathologic fractures, even that can be appreciated in the radiographs. There are different types of this cyst. The first one is the envelopmental type. This is surrounding the crown of an impacted tooth. Collateral is developing adjacent to the roots of vital teeth. These two are vital teeth. It's not affected by any other pathology. But the cyst is developing right in between them, like in a collateral way. That's why it's called as collateral. The replacement is formed in place of a tooth. You can see that the tooth is missing here, and this is formed in place of that, and that is the reason why it is also called as primordial cyst, when it is formed in place of a tooth. And extraneous is where it is seen in the ascending ramus. So these are the four types of odontogenic keratocyst: envelopmental, collateral, replacemental, and extraneous. Going to the histopathology, grossly you can see that this is the cross section of the cyst, and you can see that it is filled with yellowish white cheesy material, which is nothing but keratin. Even on aspiration, we see the same thing. So the pre-biopsy diagnosis can be aspiration, where after examination you will see that the protein is less than 4 gram per deciliter. Microscopically, there is very characteristic feature of this cyst, or the tumor as WHO is calling it, and it is very unique for this. The epithelium is stratified squamous, and it is about 7 to 8 layers thick, and it is usually uniform, as you can see here. The parakeratin, which is present on the top, is corrugated. So this kind of an appearance is called as corrugated appearance. And I hope you all know what is parakeratin. Parakeratin is when there is a remnant of nuclei and when keratinization has not been completed. So that is called as parakeratin. The junction between the connective tissue and the epithelium shows absence of rete ridges. So there is no extensions seen. It is a flat connection between the epithelium and connective tissue, which is again a significant or unique feature of OKC. The most characteristic is the basal cell layer of the odontogenic keratocyst, where the cells are all tall columnar and they're hyperchromatic, meaning the color of the nuclei is kind of enhanced, and they're polarized away from the basement membrane. This is the basement membrane, and the cells are perpendicular to that. The nuclei is away from the basement membrane, and that is why it gives a picket fence appearance or a tombstone appearance. The fibrous wall is thin and often loose in appearance, and sometimes even myxoid. Here you can also appreciate in this image the corrugated parakeratinized layer on the top, which I was talking about. Yes, this appearance is corrugated, and you can clearly see that the remnants of nuclei are present in the keratin. That makes it a parakeratinized cyst. Another thing about the junction of the epithelium and connective tissue, I told you that there are no rete ridges, correct? Another thing you must remember is that they're not usually attached. It's kind of weak, the junction between the epithelium and the connective tissue. So it kind of gets detached, as you can see in this image. The connective tissue is entirely detached from the epithelium up till this point, and here you can see that it is still attached, yeah? And this is because of the activity of collagenase. Very important and unique feature of OKC is the presence of daughter cysts or satellite cysts or microsatellite cysts, which is a cause of recurrence of the tumor. We'll discuss it more. And these daughter cysts are present within the cyst wall or the connective tissue capsule. Even mitotic figures can be frequently identified both in parabasilar and mid-spinous area. Let me just again go back to oral histology and tell you what is parabasilar and mid-spinous. So this is your epithelium. So this is your basal cell layer or stratum germinativum. Okay, it can be cuboidal or columnar or whatever. And then parabasilar, so this is the basal cell layer. Parabasilar are the cells which are around this basal layer, are called as parabasal, and mid-spinous will be somewhere here. This will be your spinous layer, and on top of that will be your stratum granulosum and stratum corneum, because we're talking about keratinized epithelium. Okay, so remember the layers: basal, parabasal, spinous, granulosum, and corneum. And the mean mitotic count which are seen in these places is 8. Antigen Chi7, which is another indicator of proliferative activity, extensive proliferative activity, which is also seen in cancerous growth, is present, or it is positive in case of OKC. And another very important antigen which is present in OKC is the keratocyst antigen, or KCA. These two are also diagnostic for the OKC. So I told you when we were discussing the histopathology that the satellite cysts or the daughter cysts are responsible for keratocysts to recur. Why do these keratocysts occur? Even after very careful surgical enucleation or any other form of therapy, which we'll discuss later, Within the first 5 years following removal, it usually recurs. Why is that? There are several reasons. The first is the presence of the satellite cysts, which I told you, and these could be retained within the connective tissue capsule, and that might cause recurrence of the tumor. The second reason is that the lining is very thin and fragile, so the surgeon might fail or he might miss a small area, and that will again proliferate and cause recurrence of the cyst. Intrinsic growth potential. The lining of the cyst has an intrinsic growth potential, and suppose a part of it is pushed into the fracture of the bone, or even while doing any kind of ostectomy procedures, if it is pushed into another area, then it has intrinsic growth potential and hence the recurrence will be seen. And apart from all of this, what we must remember is that the initiation was from dental lamina. So if there is any remnant of dental lamina anywhere else, then that can cause recurrence again. And when I said that, the surgeon might miss out a part of this thin and fragile lining, it is because he is trying to save the adjacent structures, adjacent vital structures, or adjacent teeth, and that is why some part of the lining is left behind. Conventional surgical options for a smaller tumor, it is enucleation and curettage. You might use a burr to kind of run through the bone so that if there is any lining left behind, then it can be removed by the burr. That is one step we can take to make sure that there are no recurrences. And enucleation and peripheral ostectomy, if it is slightly bigger, a part of the bone will also have to be resected. And in case of very huge tumors, there is jaw resection and reconstruction. Because the tumor is very aggressive, I told you, although it is still benign, but it is aggressive, and there are potential complications which we cannot ignore. So in such cases, the whole jaw is resected, followed by reconstruction with any kind of graft or metal plate or biomimetics. There are various options. So all this was about the aggressive type, that is the parakeratinized odontogenic cyst. Now we will talk about ortho-keratinized odontogenic cyst, which is the normal cyst, or we can say cyst without an aggressive nature. So we'll see what are the clinical features of this cyst. It occurs predominantly in younger adults, so when in comparison with POKC, it lacks a bimodal occurrence. Males are more commonly affected in contrast to POKC, which is more commonly seen in women. But the site of occurrence is mandible, and it is seen in the posterior area of the jaw. And it is unilocular in appearance, whereas POKC can be both unilocular and multilocular in appearance. And even this can grow up to 7 centimeter in diameter. Histopathologically, very, very characteristic. The keratin which you see on the top is ortho-keratinized. How will you differentiate this from parakeratinized? There are no remnants of nuclei. There's complete keratinization, so you will not see any remnants of the nuclei. It is just keratin and quite thick layer of keratin you will see on top, but the thickness could vary from region to region. And just below this, if you notice, you can see that there is granular layer. So this is the keratohyalin granules, which is very prominent just beneath the ortho-keratin. You can see this blackish, you can see the granules. So that's the keratohyalin granules. And if you notice the basal cell layer, It doesn't show the picket fence or the tombstone appearance. There is no palisading. None of those features which we see in POKC will be seen in ortho-keratinized type. So it's quite easy to differentiate the two. There will be no confusion. So the treatment for this is simple enucleation with curettage, and it doesn't cause any recurrence after the treatment is done. Coming to differential diagnosis, if at all, if you see that the lesion is associated with an impacted tooth and it is situated around the crown of the impacted tooth, then the position could lead us to get confused with the dentigerous cyst when you're looking at the radiograph. But histopathologically, they're both showing very unique features of their own, and it is quite easy to diagnose. Even the site could mimic, because even dentigerous cyst is seen in mandibular posterior area and could extend up to ramus, and angle could be involved, and even your coronoid and condylar processes could be involved. So all these things could lead to confusion when you're looking at the radiograph, but histopathologically confirmation is very easy. Radicular cyst could lead to some kind of confusion, but it is situated periapical to a non-vital tooth, which is a synchrono for radicular cyst, and that itself should give away the clue. But eventually histopathology, again, like I always say, gold standard for diagnosis. Suppose radiographically it is multilocular. Clinically, you see that the site is mandibular posterior and it's very big in size. Again, there is a confusion with ameloblastoma. But histopathology, no confusion. Both of them have their own unique features. Ameloblastoma, you will be studying about this tumor, which is again a quite aggressive tumor in the coming series on odontogenic tumors. Ameloblastic fibroma, again another odontogenic tumor. If the lesion is present pericoronal to an impacted tooth and is seen in younger individuals, could lead to some confusion, but again, histopathologically very clearly demarcated. So one of the potential complication is transformation to malignancy. Although it is a benign tumor, but there are chances that it could turn malignant over a period of time, or if there is some kind of trigger. So the criteria is, if at all the cyst demonstrates abnormally aggressive behavior, then you have to look into it very, very carefully. And if there is any ulceration or neurosensory changes, if there is any paresthesia associated, again, you should doubt it. And cervical lymphadenopathy is another giveaway where you can suspect that it is undergoing malignant changes. And microscopically, if there is a transition of epithelium from benign features to malignant features, if it is showing a lot of dysplasia, and if it is even extending into the connective tissue, then the diagnosis is quite there that it is turned malignant. So some other treatment modalities other than enucleation and ostectomy and surgical resection, there is one modality called as cryosurgical technique. This is especially used in case of recurrent cases. In case of large mandibular lesion, the conventional treatment might involve vital structures and could cause some damage, especially when liquid nitrogen is involved. Although the freezing is uniform, but it can damage the surrounding vital structures. In that case, we can use cryosurgical technique, which involves a gel, which is considered much more safer compared to liquid nitrogen. And it is also used in non-compliant patients because it is quicker. Even neodymium YAG lasers are used in treating this, and there's a review paper. If you're interested, you can go and look at it and read how laser is used in the treatment of OKCs. Very important, students, although you're undergraduates, whenever a seminar topic is given to you, try to go and refer to other books, try to read journals. So this is going to enhance your scholastic achievements, and it will make you stand out academically whenever you mention something from a recent journal which you've read, or any journal even for that matter. It need not be recent. Any important finding which you can quote from an article makes you stand out from other peers of yours. So take this tip and use it in your writing, and you will come back and thank me for it. Like I always say, take a deep breath, breathe in and breathe out. Do not get overwhelmed. Let's just recapitulate everything. So, we are talking about odontogenic keratocyst. There are two types, parakeratinized and ortho-keratinized. It is parakeratinized, which is the evil one or the bad one, and which is very, very aggressive. So, I'm going to summarize just that. Clinically, it is going to appear in the mandibular posterior area and could involve angle and ramus more commonly. It may be asymptomatic, but it could come with pain, swelling, discharge, paresthesia, and all those features as well. When you take a radiography, it is either unilocular or multilocular in appearance. When it's multilocular, it is referred to as honeycombed or suburban appearance. And you can see how far the lesion has extended in the radiography, and further CT scan or MRI will also show the borders, and if there is any fracture, and if there is any cortical expansion. All those things can be appreciated on the radiograph. Histopathologically, it is very, very, very unique. Squamous epithelium, which has parakeratin on the top, which basically means that it is having nuclear remnants. The basal layer is very characteristic. It is columnar, palisaded, polarized nuclei are away from the basement membrane, giving it a picket fence or a tombstone appearance. And we can even see mitotic figures in the parabasilar and the spinous layer. The junction between the epithelium and connective tissue lacks any ridges and sometimes can even separate from each other. It is quite a weak connection between epithelium and connective tissue. Very important feature is the presence of daughter cysts or satellite cysts in the connective tissue wall, and these are one of the causes of recurrence. And apart from that, the other causes are if there is any lining left behind during removal in order to protect the adjacent structures or any other vital structures, and if there is any dental lamina, it has a potential to cause the tumor all over again. So these are some of the causes of recurrence. The treatment is surgical enucleation if the tumor is small and unilocular, but if it is big, then we'll have to go for ostectomy and even surgical resection followed by reconstruction. So that's the summary. This is just everything together of this patient. So you can see that there's a lesion in the posterior side of the mandible, radiograph showing the involvement, extent of involvement, and we can see typical OKC in this histopathology, indicating that it's parakeratinized OKC. So let's discuss one of the questions and see how to answer it. So the question is, all of the following are true about the histopathology of POKC except. So the options given are palisaded basal layer, 5 to 8 cell thick, flat retroridges, keratohyalin granules. Does POKC have palisaded basal layer? Yes, it has, and that's what gives it a tombstone appearance or a picket fence appearance. Is it 5 to 8 cell in thickness? Yes, it is, and it is quite uniform. Does it have flat ridges? Yes, it does. The junction between the epithelium and connective tissue is flat and it is usually weak and separate from each other. Is there presence of keratohyalin granules? The answer is no, because keratohyalin granules are seen in the ortho-keratinized odontogenic keratocyst and not in the parakeratinized type. So that's how you answer. Do not jump into conclusions and do not say, oh, they have given a particular number, so probably there is some mistake in it. It might not be 5 to 8, maybe it is, say, 10 to 20, and do not go and answer that. Try to recollect the features, try to remember the image. Always it is helpful when you remember the image. For more such MCQs, please visit my website where you will find a lot of such other MCQs with explanations and a few MCQs for you to practice on your own. These are my references, students. Thank you and keep smiling.